Welcome to the deep dive. Ever felt like you needed a shortcut to really grasp a complex topic? Especially, when it affects something as vital as animal health. Today, we're doing exactly that. We're taking all your provided sources, a really fascinating deep dive into equine osmolality, imbalance, pathology, and treatment. And we're going to distill it down, give you those critical insights to truly understand a concept that can literally be life or death for a horse. At its heart, we're talking about osmolality in horses. Sounds technical, I know, but it's fundamentally about this incredibly delicate balance. The balance of fluids and dissolved particles or solutes within a horse's body. And here's the thing, when that balance goes wrong, well, the effects can be dramatic.
It's true. What's truly fascinating is how this seemingly abstract biological term, osmolality, it directly impacts everything from how individual cells function, all the way to a horse's overall neurological stability. Our mission today is really to demystify osmolality, explore what happens when it goes awry, and explain why understanding its intricacies is so crucial for any horse enthusiast or professional out there.
Okay, so let's really dig into this osmolality.
Yeah.
What exactly is it, and what's the sweet spot, that normal range we're aiming for in horses?
Right. So osmolality is essentially the concentration of dissolved particles in a solution. Think of it like how much stuff you've dissolved in water. In horses, we're primarily concerned with serum osmolality, that's the concentration in the blood plasma, and also urine osmolality. And maintaining this normal concentration is absolutely critical. It's key for fluid balance throughout the body, for how every single cell functions, and for overall bodily stability, what we call homeostasis, that constant, stable internal environment. And the normal range for serum osmolality in horses, it's surprisingly precise, actually, typically around 280 to 305 milliosmoles per kilogram, or masum kg.
Wow, 280 to 305. That's a pretty tight window, isn't it?
It really is, and that narrow window is a really important insight. It shows just how little room for error there is when it comes to a horse's internal chemistry.
Okay, and what are the main ingredients then, the key solutes that are actually setting this concentration?
Yeah, the primary effect of osmoles, those are the critical particles that truly pull water across cell membranes. They don't just slip through. They are sodium, glucose, and to a lesser extent, urea. Those are the big three we constantly monitor because they're the main drivers of where water goes in the body.
Got it. Sodium, glucose, urea. Okay, so if that concentration goes too high, that's hyperosmolality. This is where it gets really impactful, right?
Yeah.
What does that actually mean for a horse's body and for its cells specifically?
Exactly. Hyperosmolality means there's just too much solute relative to water in the fluid outside the cells. Imagine a juicy grape, right? And you drop it into super salty water. What happens?
It shrivels up. The water gets sucked out.
Precisely. Water is sucked out of the grape. That's basically what happens to a horse's cells. They become dehydrated, they shrink, they shrivel. And this is particularly dangerous for sensitive cells like those in the brain, which are highly, highly susceptible to changes in water content.
That's a powerful image. So what are some of the most common situations that could cause a horse to become hyperosmolar? I'm thinking, like you said, losing too much water or maybe taking in too much salt.
You're absolutely on the right track. The leading causes typically involve either a water deficit or a solute excess. So first, you've got dehydration and hypernatremia, high sodium. This is often the big one. It could be just insufficient water intake. Maybe their access is restricted, or the water tastes bad, or they physically can't drink because of choke or some neurological issue. Or it could be excessive water loss. Think severe sweating from, say, intense endurance exercise or extreme heat. Or prolonged diarrhea, where the water loss really outstrips the electrolyte loss. Or even excessive urination from conditions like diabetes insipidus. That's a rare but critical one where the body can't regulate water properly because of a hormone issue, ADH. They produce huge amounts of dilute urine.
Wow.
Or it could be severe kidney disease or even high blood sugar, which is hyperglycemia.
Right, hyperglycemia. You mentioned that's one of the key solutes.
Exactly. High blood sugar, often seen with severe stress or illness. It acts as an effective osmol itself, pulling water out of cells. Now, full-blown diabetic ketoacidosis, that's less common in horses than in, say, dogs or cats, but severe hyperglycemia can still significantly raise osmolality. And then we also sometimes see iatrogenic causes, meaning caused by medical treatment, like giving really concentrated fluids without enough free water. And even though rarely, salt poisoning if a horse gets into a lot of salt and doesn't have enough water available to balance it out.
Wow. Okay, so a lot of potential triggers there. What are the signs then? What should we be looking out for if you suspect a horse might be experiencing this? Are there subtle cues?
Yeah, the signs are primarily those of dehydration and, reduced blood volume, but critically also that cellular dehydration. So you might notice increased thirst, polydipsia if the horse is still able to drink, of course.
Mhm.
You'll see the classic dehydration signs, tacky mucous membranes, slow capillary refill time when you press on their gums, decreased skin turgor, the skin stays tented when you pinch it,
Right, the skin tint.
sunken eyes, an elevated heart rate, maybe reduced urine output. But here's a crucial insight and where it gets really serious, the neurological signs, because those brain cells are shrinking.
Ah, right.
You might see dullness, lethargy, weakness, maybe an unsteady gait that's ataxia, disorientation, tremors, seizures, and in severe cases, even coma,
Oh,
especially if the osmolality rises very, very quickly.
that sounds incredibly serious.
It is. And sometimes fever can also be present, either contributing to the dehydration itself or maybe signaling an underlying illness that's driving the whole imbalance.
Okay, that's a clear picture of the too concentrated problem. Now, let's flip the coin. Hyposmolality, when the body fluids become too dilute, too much water relative to the solutes. What's happening inside the horse then?
Right. So in this opposite scenario, water shifts into the cells. Think of our grape again, but this time it's like a raisin dropped into pure distilled water.
Okay, so it would swell up.
Exactly. The water rushes in, making the raisin swell. That's what happens to the cells when the surrounding fluids are too dilute. This leads to cellular swelling, and again, it's particularly concerning for the brain. It causes cerebral edema swelling of the brain. And the critical insight here is that while one condition causes cells to shrivel and the other causes them to swell, both have equally severe, potentially life-threatening consequences, especially for the brain trapped inside the skull.
That makes a lot of sense. Both extremes are dangerous. So what are the common culprits behind a horse becoming hyposmolar? Where does all that extra water come from, or where did the solutes go?
Causes typically fall into sort of two main buckets. First, you have water overload or dilution. This can actually be behavioral, like psychogenic polydipsia, where horses just drink compulsively way too much water.
Really? They just drink too much.
Yeah, it happens. But maybe more often, it's iatrogenic again, caused by medical treatment, like over-administering hypotonic intravenous fluids with low salt content, or giving very large volumes of plain water through a stomach tube when it's not actually needed. And while it's very rare in horses, an excess of that antidiuretic hormone, ADH, a condition called SIADH, can also cause the body to hold on to way too much water.
Okay, so too much water going in or being held onto. What's the other bucket?
The other side is sodium loss, or hyponatremia. Since sodium is the main effective osmol, if you lose a significant amount of sodium, your osmolality can drop. This commonly happens with profuse chronic diarrhea, especially if the horse is losing more sodium than water in the diarrhea, or with fluid getting trapped or sequestered within the GI tract, like during some types of colic with ileus, or maybe prolonged gastric reflux where they lose sodium-rich fluids. Other rarer causes could be certain salt-wasting kidney diseases, maybe excessive diuretic therapy, or extremely rare cases of hypoadrenal corticism, Addison's disease in horses.
Got it. And the signs for hyposmolality? I'm guessing those neurological signs are back, but maybe looking a bit different because now the brain is swelling.
Precisely. The signs are primarily linked to that cellular swelling, especially in the brain. So you'll again see neurological signs, but this time they're due to the brain swelling inside the rigid skull. Things like dullness, lethargy, ataxia, weakness, tremors, seizures, altered mental status. And these are often much more severe if the osmolality drops rapidly. The brain just can't cope with that sudden swelling.
Okay.
You might also see peripheral edema that's swelling in the tissues, often visible in the lower legs or under the belly, because fluid is shifting out of the blood vessels and into the surrounding space. And of course, you'll likely see signs related to whatever the underlying cause is, like the ongoing diarrhea or signs of colic.
Right. Okay, so we painted a pretty clear picture of what happens when osmolality goes wrong, both too high and too low, and why it's so incredibly serious.
Yep.
Now, the detective work. How do vets actually diagnose these imbalances? What kind of testing is involved?
Yeah, the diagnosis really relies on putting several pieces of the puzzle together. First, those clinical signs we just talked about are absolutely key. Observing neurological changes or assessing the horse's hydration status, that immediately raises a red flag. Then we move to blood work, specifically measuring the serum osmolality directly. This is done using a machine called an osmometer, often using a method called freezing point depression, which is the most accurate way to get that precise number.
I found something really interesting in the sources about calculated osmolality. What's
Yeah.
that, and how does it compare to the measured one? Is it just like a backup check?
That's where we gain a truly insightful diagnostic tool. It's not just a backup. You can estimate the serum osmolality using a formula. It basically factors in the main drivers we talked about. 2 times the sodium level, plus the glucose level divided by 18, plus the BUN level divided by 2.8.
Okay, so you calculate that.
Right. And this isn't just for fun math. It's incredibly useful because it allows us to identify something called the osmolar gap.
The osmolar gap. Okay, what's that telling us? Why calculate it if you measure it?
Good question. The osmolar gap is the difference between the measured osmolality, the number from the machine, and the calculated one from the formula. And here's the aha moment. If this gap is bigger than expected, usually greater than about 10 to 15 mg/kg, it signals that there are other unmeasured osmoles present in the blood.
Unmeasured osmoles.
Yeah.
So other things contributing to the concentration that aren't sodium, glucose, or urea.
Exactly. These are substances we aren't routinely measuring in that basic calculation, but they are significantly contributing to the overall concentration and pulling water around. This can be a critical clue. It might point towards things like severe metabolic acidosis where lactate is really high, or perhaps the presence of toxins like a ethylene glycol antifreeze or methanol, or even certain medications like mannitol if they've been given.
Wow.
So it tells us there might be a hidden problem beyond just the big three players.
So the gap helps us look for hidden troublemakers. That's actually incredibly clever. What other blood or urine tests are crucial in this detective work then?
Precisely. Beyond osmolality itself, we look at a whole panel, really. Electrolytes, definitely. Especially sodium, as it's the primary driver of osmolality. Blood glucose, obviously, to check for that hyperglycemia. BUN and creatinine, those are key indicators of kidney function. Are the kidneys working properly?
Right.
And packed cell volume, PCV, and total protein, TP. The PCV, which is the percentage of red blood cells, and the TP level, they're typically elevated in dehydration because the blood is more concentrated. But they might be normal or even low if the horse is overhydrated or has lost protein.
Okay, that makes sense. And urine tests.
Yes. Finally, we analyze urine tests, specifically urine-specific gravity, USG, and urine osmolality. A high USG in a dehydrated horse is generally a good sign. It means the kidneys are doing their job, trying to conserve water. But if a dehydrated horse has low or isosthenuric urine, meaning the urine concentration is basically the same as the blood plasma, it's not concentrated at all. That strongly points towards a problem, either a kidney concentrating defect or maybe that diabetes insipidus we mentioned. So these tests help us answer a crucial question. Is the horse's body responding appropriately to the imbalance, or is there a deeper underlying problem that needs specific treatment?
Okay, this brings us to the really critical part, treatment. The sources make it abundantly clear that managing abnormal osmolality is an emergency, absolutely, but also that simply correcting it fast isn't the answer. You've hinted at this. Why is gradual correction so incredibly important here? Why the caution?
You've absolutely hit on the core challenge and the most critical insight for treatment. Yes, it's an emergency, but rapid fluid shifts can be catastrophic, especially for the brain. They can dramatically worsen neurological signs. Think back to our shriveled brain cells and hyperosmolality. If you flood them with plain water too quickly, they swell up dramatically, causing severe cerebral edema, basically drowning the brain cells from the inside.
Oof, okay.
Conversely, if you correct hyponatremia, the too dilute problem, where cells are already swollen too fast by adding lots of solute, it can lead to a devastating neurological condition called central pontine myelinolysis. This is where the protective myelin sheath covering nerves, particularly in a part of the brainstem called the pons, gets stripped away. It causes severe, often permanent neurological damage.
Wow, so it's a real tightrope walk.
It absolutely is. It's a truly delicate balance, a slow dance to bring the body back into harmony without causing more harm in the process. Slow and steady definitely wins the race here.
That really puts it into perspective. Okay, let's break down the treatment for hyperosmolality first, the too concentrated state. How do you bring those solute levels down safely without causing that dangerous brain swelling?
Right. The main goal is twofold. Provide free water to dilute the solutes and reduce the overall solute concentration, primarily by correcting the dehydration and, crucially, treating the underlying cause. Fluid therapy is the absolute mainstay. Now, interestingly, we generally start with isotonic crystalloids, things like lactated Ringer's solution or Normasol R. These are balanced salt solutions, pretty similar in concentration to the body's own fluids.
Wait, isotonic? Even though they need free water, why not start with something more dilute?
That's the caution kicking in. Even though the ultimate goal is to add free water, giving hypotonic fluid fluids significantly less concentrated than blood, like plain water or half-strength saline too quickly right at the start, especially intravenously, carries that high risk of causing rapid fluid shifts and cerebral edema. So we start isotonic to stabilize the patient and begin rehydration more gently.
Ah, okay. Safety first.
Exactly. And the most crucial part, as we stressed, is the rate of correction. Hyperosmolality and the associated hypernatremia must be corrected slowly, usually over 24 to 48 hours, sometimes even longer. The aim is to decrease the serum osmolality by no more than 0.5 to 1.0 millas kilogram per hour. Or, looking at sodium, decreasing it by no more than 0.5 milliequivalents per liter per hour. This slow pace allows those brain cells time to gradually adapt and pull solutes back inside, preventing them from swelling suddenly as water enters.
So really slow adjustment.
Very slow. Once a horse is more stable, and especially if we know there's a significant pure water deficit, then maintenance fluids containing more free water might be carefully considered. Things like 5% dextrose in water, D5W, or 0.45% saline, half-strength saline, maybe with some dextrose added. And of course, if the horse is conscious and able to drink, we absolutely encourage oral water intake. That's often the safest way to provide free water.
Makes sense.
And if hyperglycemia is a big part of the picture, then insulin therapy is necessary to bring blood sugar down. And throughout all this, the big picture is addressing the specific underlying cause, treating the diarrhea, cooling the horse down from heat stress, giving ADH hormone if it's diabetes insipidus, and constant monitoring blood values, neurological signs is absolutely key.
Okay, very clear on the hyper. Now, what about hyposmolality? When there's too much water, things are too dilute. How do you safely increase that solute concentration without causing that myelonolysis you mentioned?
Right. Here, the goal is the opposite. Increase the solute concentration and gently remove or restrict the excess water. Now, if the horse has acute severe neurological signs like seizures due to brain swelling, that's an immediate emergency within the emergency. In that specific case, a small, carefully calculated bolus of hypertonic saline might be given. That's a very concentrated salt solution, like 7.2% sodium chloride.
Hypertonic saline. So that pulls water out of the brain cells.
Exactly. It's given slowly, maybe 2 milliliters per kilogram over 10 to 15 minutes. It acts quickly to create a higher concentration in the blood vessels, pulling water out of the swollen brain cells to temporarily relieve the pressure. But this is a very specific short-term measure for severe cases.
Okay, like an emergency rescue. What about the ongoing correction?
For the ongoing gradual correction, we use isotonic saline, 0.9% sodium chloride, or other isotonic fluids. We absolutely avoid hypotonic fluids because they would just make the dilution worse. And again, slow correction is absolutely paramount. We aim to increase the serum osmolality, or the sodium level, by no more than that same rate. 0.5 to 1.0 mass m kilogram per hour, or 0.5 millieql of sodium per hour over 24 to 48 hours. This slow increase prevents the rapid shrinkage of brain cells that can lead to central pontine myelonolysis.
Same slow speed, just go in the other direction.
Precisely. We also need to restrict free water intake until the osmolality normalizes. Stop the source of the excess water if possible. And just like with hyperosmolality, we have to aggressively treat the underlying cause, stop the fluid losses from the GI tract, discontinue diuretics if they were the cause, manage SIADH if that's the rare diagnosis. And again, continuous monitoring of osmolality, electrolytes, and crucially neurological signs is non-negotiable.
Right. It sounds like incredibly intensive monitoring for both conditions. We've talked about the imbalances, how they're identified, how they're treated. This all sounds like really serious critical care. What factors ultimately determine if a horse will pull through? What influences the prognosis?
You're right. If we connect this to the bigger picture, managing osmolality imbalances is definitely a challenging aspect of equine critical care. It demands meticulous attention to detail and continuous, careful monitoring. The prognosis, well, it really heavily depends on several factors. First, the severity of the imbalance. Just how far off is the osmolality? Extreme deviations, say below 250 mLs per kilong on the low end or above 330 mLs per kilong on the high end, those carry a much poorer prognosis, especially if profound neurological signs are already present when they arrive. The farther they deviate from normal, the harder it generally is to bring them back safely.
Okay, so how bad it is matters a lot. What else?
Second, the rapidity of onset. How quickly did this imbalance develop? Acute, rapid changes are often more detrimental than gradual ones. Why? Because the brain and other cells have much less time to adapt and compensate. A sudden shock is harder to handle.
That makes sense. Quick changes are tougher.
Third, timeliness of diagnosis and treatment. This is huge. Prompt recognition of the problem, and perhaps even more importantly, initiating appropriate and gradual correction significantly improves the chances of a good outcome. Delays in diagnosis or errors in treatment like correcting too fast can be devastating.
So getting it right and getting it right early is key.
Absolutely. Fourth, the underlying cause. What started this whole cascade? The prognosis of the primary disease often dictates the overall prognosis for the horse. For example, a horse with severe infectious colitis causing hyponatremia has a very different, often much graver outlook than, say, a horse with psychogenic polydipsia causing mild hyposmolality, where you just need to manage the water intake. You have to fix the root problem.
Right, the original problem is still there.
Exactly. And finally, the development of complications. Did the horse suffer any lasting damage during the imbalance or its treatment? Any persistent neurological deficits? Did the kidneys take a hit and develop failure? Did other organs get damaged? Any of these complications will certainly worsen the long-term prognosis. It's a powerful testament, really, to how interconnected all the bodily systems are.
Wow, what a deep dive into this microscopic yet profoundly impactful world of solutes and water in horses, from, dehydration leading to those shriveling brain cells, to water overload causing them to balloon up and swell. It's crystal clear that keeping things within that precise 280 to 305 millicurie range is just absolutely vital for a horse's well-being.
Indeed. Understanding these imbalances, from recognizing the often subtle telltale neurological signs to appreciating the crucial role of things like the osmolar gap in diagnostics, it truly highlights the incredible complexity and the delicate balance of the body's internal environment. And I think the absolute key takeaway for you, our listener, whether you're a vet tech, a vet student, an owner, or just someone fascinated by equine health, is the critical importance of gradual correction during treatment. That slow, steady approach is paramount to prevent further, often irreversible, harm.
So what does this all mean for you? Well, next time you hear about a horse dealing with something like severe colic, or struggling with intense diarrhea, or maybe battling extreme heat stress, you'll have a much deeper understanding of that invisible battle happening right down at the cellular level. And this makes me wonder for you, how might understanding these incredibly delicate fluid and solute balances in horses, with their often subtle, sometimes misleading clinical signs, how might that influence your own awareness and observation of other animals, or maybe even humans, when their hydration or electrolyte status might be in question? Definitely something to consider.